Hi all, I'm Jana Whitmarsh. I'm one of the senior nurse recruiters here at Nebraska Medicine. We'll give it a few more minutes, but I just wanted to make sure that everyone is, I guess, in the right breakout room. So this particular session is going to discuss some different general ICU and mid-level care units. So if you are not in the right room, you can maybe just raise your hand or come off mute, and we can try to get one of the admins to come in and get you to whatever room you're supposed to be in. Okay, we'll go ahead and get started because we just have 30 minutes and it goes by quick. We have 6 different managers in this group that are going to be telling you a little bit more about their units and available for any questions. So supervisors and managers that were in this group last time, it should be the same group of us. We'll just kind of follow the same format. These managers are going to tell us a little bit more about life on their unit, talking about the culture, patient populations, nurse ratios, anything that maybe makes their unit unique and stand out. I'm going to break things up a little bit and go in a different order than last time. So we're going to actually go in reversed order. So Christina, do you mind starting first?
Not at all. Thank you. I'm Christina Johnson. I'm the manager of 7UT. 7UT is a new unit at Nebraska Medicine. We take care of COVID positive patients or patients suspected of having COVID. So this unit was formed in response to the pandemic last March. When it was first formed, we were staffed primarily by nurses and care techs from all different areas throughout the organization. So people floated here to take care of our patients. The decision was made after a few months that I think everybody realized that the need for COVID was going to be around a little longer than we had originally anticipated. So the decision was made to hire a core team for our unit. We're still in the beginning to middle phases of hiring our team. We have about 65% of our care techs hired and just under 30% of our nurses hired. It's a really unique opportunity for anyone that's joining our team right now because anybody that's new with our team gets to help set the culture, set workflows, really kind of help decide who we want to be and what we want our unit to look like. That being said, so like I said, we're a new unit and we take COVID patients. The goal would be that our unit would be the only unit at Nebraska Medicine taking COVID patients. Over the course of the last several months, there's been lots of units that have taken care of COVID, but as the numbers come down, we will be the permanent unit. So that being said, we would take any patient that would come through the door with COVID. So we take all levels of care. So we take med-surg patients, progressive care patients, and ICU patients. And we get patients of varied backgrounds. So we get some cardiac patients, we get traumas, we get oncology patients, we get neuro. I mean, we really get the full gamut of everything. Our unit would also take pediatric patients if there was a pediatric patient suspected or confirmed of having COVID. That being said, the pediatric patients that we've seen so far, or that population, has been pretty minimal. The pediatric patients that we have seen are typically here for other medical reasons and just incidentally also have COVID. Because the numbers are so small, our nurses will not be required to maintain competencies in pediatrics. We will likely always depend on the pediatric unit to float over nurses to take care of those pediatric patients. Our leads and relief leads on the unit are PALS certified. They've gotten some extra training so they can help support those nurses while they're here, but our core staff will not be required to take care of pediatric patients. Ratios on the unit is really kind of dependent on the acuity of the assignment. So our ICU patients may be in a 1-to-1 or 1-to-2 ratio. Our med-surg patients are usually in a group of 3 to 4, just depending on kind of what's going on with those patients. Like I said, we really get the full gamut. So we have, very, very sick ICU patients that are paralyzed, prone on the vent, and lots of drips. And then we also have pretty stable med-surg patients that might just be on a liter or two of oxygen and are, walking and talking on their own, and you're able to kind of build relationships with them. I kind of think it's the best of both worlds. It's a different skill set between being med-surg and being ICU. So you know, really getting comfortable with both, I think just makes a very well-rounded nurse. As far as the culture on the unit, like I said, since we're new, we're just kind of building that, but I am looking for people that are very flexible. Just the nature of COVID, things change and they ebb and flow all the time. There's been times that our unit has been completely med surg. There's also been times that our unit is completely ICU. So people that are comfortable with changes and are willing to kind of roll with the punches as, you know, the COVID population changes and as we learn more about the disease, obviously, you know, the treatment and the way we respond to COVID is different now than it was, you know, back in March when all of this first started. So learning as we go. But it's a new and exciting place to work. I think it's a pretty unique opportunity to be part of something from the ground up. Any questions for me? Sorry. Thank you.
Thank you, Christina. So those of you that were in other breakout sessions, I guess, prior to our guest speakers, we're just going to kind of follow the same format we did in our first session. So as the managers are speaking, they'll give you some time at the end to ask questions specifically about their unit. And then once we get through all the managers, I'm guessing we'll 5 or 10-ish minutes at the end that you can ask random general questions. Otherwise, we can kind of go over things such as the interview process. So Nandi, if you don't mind going next.
No problem. Hello, I am Nandi Bruns. I'm the manager of Down Critical Care. Our unit is very unique and different compared to other units within the organization. We are a step-down critical care. However, we are aligned with the intensive care units. We're on the same division together. Our unit is a specialty unit. However, our specialty is very broad. We take care of trauma patients, transplant patients, which includes liver, small bowel, kidney, pancreas, and lung. We take care of medical patients, which are the chronic pulmonary diseases, which includes ventilators. And that's what makes us stand out against the other areas in the organization. We also take specialty medications, drips, pressors, and sedation. Our ratios here on step-down critical care are 2 to 3 patients. There are times where you may have to take 4, but those are usually due to staffing issues within the whole organization where every unit is stretching, but typically it's 2 to 3 patients. Our unit is very small. We only have 12 private beds, and we're a small knit group. We're all young, we're all learning, and we're a great family, and we depend a lot on teamwork. I personally live by the golden rule, and so that's one of the expectations on the floor is to treat others, especially patient and families, like you would want to be treated. Other things with our unit is to help you succeed is if you're eager to learn, you're adaptable, and you are able to push yourself, because on our unit it's very fast paced and moving very quickly. It forces you to really hone in on those critical thinking and time management skills. So it's a great area to start your career, or if you have been a nurse for a while, it's a great area to see everything and learn so much, because every day is different down on our floor. That's about all I have.
Does anyone have any questions for Nandi? Okay, just a quick call out. We have a pretty full room this session. Our last session did not have as many participants in it. So unless you are speaking, like presenting or asking a question, if everyone can please just mute their phone. Otherwise, with so many people in the room, we tend to pick up a lot of background noise. Okay, thank you, Nandi. So if we can have Val Becker go next, please.
Hi guys, I'm Val Becker. I am from the Cardiac Progressive Care Unit, now known as CCU PCS, post cardiac surgery. We specialize in all of the cardiac surgeries and the vascular surgeries, mainly heart transplants and lung transplants. We work very closely with the cardiac vascular ICU. So we will get a lot of those patients. Once they are stabilized, they will come and transfer to our unit as a step down floor. We also will work with HVU, which is the Heart and Vascular Unit. So we work very closely with them also. And if they have any patients that have a higher acuity need, they will come up to us. We have a patient ratio of 1 nurse to 3, sometimes 4, depending on acuity. And then we've also had the opportunity to increase our specialties. So we are now taking drips that are more titratable drips. We are now taking balloon pumps, which is something that was only going to CVICU, so we've had the opportunity to do that. So a lot of learning opportunities, a lot of education for new grads and new nurses. As far as vascular, we work very closely with the vascular unit, and we do a lot of FEMPOP BiPAPs, a lot of fasciotomies, things that are all vascular related. We have a unit that strives for teamwork. We work very well together. We have to. We get the day done by working together and working very hard. And we have very good techs, and they really make or break your day. And we've got some really great techs on our unit. Another thing that we do is we have a cardiac fellowship. So any new nurses that come to our unit, and also the CVICU and HVU, they do a 16-month fellowship. And what that does is it allows them to get that cardiac experience. They have training, they have very specific classwork for the transplants, how to treat those transplants, medications for those transplants, how to prevent rejection, a lot of education for post-care follow-up. And it's a 16th-month program, which is very unique to our hospital. And our environment, it's fun. We work very well together. We have a great time, and we also encourage new staff, new students. We've hired some on for the May grads, so we welcome everybody.
Thank you, Val. Val Driscoll, would you like to go next?
Sure. I'm Val Driscoll. I'm the manager of the Medical Intensive Care Unit. It's a little bit difficult to tell you what our patient population is because we switched from our normal medical population last spring to taking care of COVID positive and COVID rule out patients. Just last Friday, we moved the COVID patients out of the unit because of the decrease in the census. However, that could change. I could get a phone call in 2 minutes and we could be taking COVID patients again. It really is, like Christina said, it's kind of ebbs and flows. Prior to COVID, our main populations were the same populations that you'll see in med-tele areas, only at a higher acuity. So instead of sepsis, you're going to see septic shock. Instead of GI bleeding, it's GI hemorrhages, liver failure, kidney failure, intentional and unintentional overdoses, respiratory problems like COPD, pneumonia, and then we take the pulmonary hypertension patients that require being started on Velitri or maybe Remodulin. Other than that, our culture is the same as everybody else's. We really preach that those I teach values, making sure that everybody is working together. I can guarantee you that when COVID hit, we had to work as a team. It was very difficult. It was a lot of teamwork. It was supporting one another and really having courage, because when it first began, everyone was terrified to take care of those patients. They've kind of struggled through it and come out on the other side, and I can guarantee they'll be better nurses in the end for it. For the type of individuals that I look to hire, I just want people that want to learn. You're going to learn every day. And I think the hardest thing, or one of the worst things that you could do as a new grad coming into, or even an experienced nurse coming into an ICU, is trying to portray that you know more than you do. That's the last thing we want to see. We want to see people coming in that are just complete and total sponges. What can I learn today? And even if you've heard it 10 times from 10 different people, that 11th time, you may learn something new. We learn something new every day. I've been a nurse for over 20 years. I guarantee you, I go home every day going, I never knew that. And you learn from each other all the time. For ratios, we have the same as the rest of the ICUs. So it's normally 1 nurse to 2 patients. Occasionally, if our patients are really, really sick, especially like our COVID patients that were prone and medically paralyzed and sedated and, you know, on 4 pressors and 4 sedation meds, those patients, we're not going to give you another patient with them. Those are normally a 1-to-1. And we have the same kind of leadership structure as the other units. You have a manager, and then you have supervisors and leads. But really everyone should be holding each other accountable and living those I teach values. So that's about it for MICU. Who knows what will be tomorrow, but right now we're just our regular medical patients.
Does anyone have any questions for Val specific to medical ICU? No? Okay, Tracy, you're up next.
Hello, everyone. I'm Tracy. I manage the Warner Progressive Care Unit. So we're located in the Buffett Tower. We've been opened almost 4 years now. We are a progressive care unit. We do take up to step-down care, level of care patients. And any oncology patient that needs resections of anything, if they're higher acuity, any closer monitoring, they will come to us, either from the ICU, transfer out after a day or 2, or straight from surgery. So one of the bigger surgeries is the thoracotomy patients. They come to us straight out of the recovery room from the OR. I think our average length of stay is about 5 to 6 days. Our ratios are about 1-to-3 or 1-to-4 based on acuity level. And that's for days and nights. Let's see, we love to teach. I think our culture, in addition to teamwork, like everybody else, is just teaching and growing our staff. We love to do that. You gain a lot of skills, clinical skills on our floor, because we have so many different things, chest tubes and trachs, lots of drips and lines, wound vacs. So there's just a lot to learn skills wise. And I think, like I said, we like to grow our staff. We do have a program set up with the Warner ICU. So we will cross-train staff after they've been with us for about a year or 2. If there's an interest and they have positions open, we've cross-trained, I think, 5 people so far. And so they can be flexible and go back and forth between the ICU and PCU. And it's good to have that higher skill level on our floor too, because they make great resources for our other staff. What else do I wanted to say? I think that's all I can think about right now. So thanks.
Any questions for Tracy regarding oncology progressive care? Okay, Chad, you want to go ahead and tell us more about surgical ICU?
Sure. Okay, I'm last, so this is the last speech or spiel. I'm looking at my background, and no, they did not stick me in a storage closet. It is actually my office. So sometime when you're up here, I'll show you what the rest of the room looks like. So I manage the surgical ICU. It's a 12-bed unit. One of the things that somebody asked in the first group, we are all adult units. Some of us will take 14 or 15-year-old kids if they're adult size. Christina in the 7UT does have peds, but from what she was told before, the peds nurse float in to help care for those peds patients. So we're all adults. In the surgical ICU, it's trauma and transplant. There are 2 biggest patient populations. Trauma is intentional injury victims, motor vehicle accidents, and falls. Transplant, we do everything below the diaphragm, liver, small bowel, some kidneys, and some pancreases, depends on if they have other comorbidities, but most of them go to so too. Most of the transplant that we would see up here, I would say 95% or more are going to be, and I say liver or a combination or a multi-organ transplant with the liver involved. Orientation is going to be very similar across the critical care division. New grads, we usually figure about 12 weeks in addition to the nurse residency. And then we would, if you have experience, we would go from anywhere from like 6 weeks. Somebody with prior ICU experience, we've been oriented in 4 weeks. You know, very much like Val Driscoll and Andy talked about the culture. Teamwork is huge. Learning is huge. I think if you ever find yourself in a situation where you think you've seen it and done it all, I don't think you're doing yourself or your patients a service. There's always something to learn. Nurse to patient ratios is pretty standard across the division too. 1 nurse for 2 patients, and kind of like Val said, depending on the acuity, you may have a 1-to-1, and then on the other side of the equation, you may have 3 patients, 2 at sometimes, but typically it's 1 to 2. I think I caught everything there, Jana. Just real quick, just a show of hands, is everybody going to be a new grad in May? Can you raise your hands real quick? The ones that are on video. See Alexis, Bethany, Quinn, and I can't say, is it Noli?
Sorry, it's Noelle, and I know I'm a nurse here at Nebraska Medicine, but do case management.
Where do you work?
Case management for urology.
Okay, then how about you, Nick?
Say the.
I'm a talent acquisition and sourcer for Nebraska Medicine, but it's been great.
Oh, that's okay. All right.
It's been great to learn about all your units.
Then Ashton.
Oh, I raised my hand. I'm gonna be a new nurse. Yeah, so.
Okay. And then I think Deloria. I feel like I'm calling people out. That's not my intent. I just want to know who I'm talking to.
Can you hear me?
Oh, I hear you,
Yes, we
John.
can hear you, John.
Yeah, I've been a nurse for 13 years. I've been trying to get into a hospital. I have an associate's degree, RN. I've been doing skilled nursing for about 12 years. So what do you think?
I think there's an opportunity for everybody here, John. It's just finding the right fit. That's one of the things I love about this organization. I don't think there isn't anything we don't do. We just got to find a good fit for you, John.
Yeah. So what's the next steps from here?
I'll let Jana talk to that.
Yeah, that's actually a great question. And Chad, good call out, because I was going to ask the same question as far as what our, I guess, ratio looked like as far as new grads versus experienced. But next steps of the process is to get you guys to start applying for some jobs. So when you put your application in, recruiters generally, for the most part, are doing a touch base either via phone or via email within 24 to 48 business hours of applying. And then when we see fit, we will do a phone screen with the recruiter. At that time, we either make recommendation to move forward to a manager interview or potentially talk about maybe other areas that might be a little bit better fit. We schedule interviews with the manager. We're kind of in a tricky time here or spot over the last 11 months where we used to do, majority of our interviews would be on-site and face-to-face. We are not doing any on-site interviews at this time due to the visitor restrictions. So all of the interviews are done with the manager either via phone or via Zoom, depending on that manager's preference. Those interviews usually last about 1 hour. The types of interviews that we do are called behavioral related. So they're very open-ended questions where we're going to ask you to refer back to one specific example. The more real-life example and details you can give us, the better. I think several people have kind of mentioned Nebraska Medicine values. I know when Eric Borgmeyer was speaking, he called out the the I Teach values as well. So that's something to become very familiar with, or have some knowledge of the Nebraska medicine values during that interview, because a lot of those questions are going to stem, from those I Teach values. And so by guys asking questions, going off the mic and asking questions, and those of you that have decided to go ahead and go via video and share your face, you guys are already actually displaying one of our I Teach values, which is courage. So we appreciate you guys coming tonight and participating. Does anyone have any specific questions about the application and interview process? No. I did share with the last group, if you guys think of a question after today's call, or maybe didn't want to ask them in front of everybody, there was the toolkit that was shared as a link at the beginning of today's presentation. And that does reference all of our recruiters' emails. So you could just pick any of us out in the bunch and email us and have kind of a little bit more private or one-on-one time. So I did get, I'm not sure if everybody saw that message pop up, but I think we're down to like a 4-minute countdown before we go back to the main room again. Does anybody have any questions they thought of? Okay, no questions. So what we did to fill some time in the last session was we just had a few managers kind of share tips or preferences and what they look for in their interviews.
This is Mandy from Down Critical Care. I'll start. I think the big thing for all managers is when you're answering your questions, answer questions with specific examples and describe what you did do in the situation, not what you would have done in the situation. So really think through some scenarios. It doesn't matter how small you think it is or how big, just how specific you are would be the most helpful.
And I'll just say for the new grads, don't think that you have to answer all of those questions with patient care experience. We are also looking for people with soft skills. If you were a waitress, having to deal with the public that is, demanding and, in a rush, those are just as important, because we can teach you all the nursing skills you'll need. How you interact and the communication that you have with the people around you is vitally important.
One other call out too, especially for May new grads. I mean, we welcome anybody to apply, the sooner the better, but May new grads, it is not too soon to start applying and interviewing now. We have actually hired a good portion of individuals graduating in May already. So they started applying in that November and December timeframe and have already interviewed and been extended offers and have accepted.
Awesome. Do you guys accept associate RNs?
We do. There are a few extra steps during that process. The preference is for a bachelor's degree. However, that does not mean that we do not hire associate degree nurses.
Okay.
Have a preference if you're an associate degree nurse to have experience. And then we have additional conversations of, if you have an associate's degree and you have experience, we have conversations of where would be the best place to start applying. So for an example, if you have experience in the OR and you have an associate's degree, it's probably best to start off applying out in the OR, not completely do a switch as far as specialties. And then we go through an approval process with our leadership. And then if an offer is extended, we would just ask that you sign an agreement that you'll obtain that bachelor's degree within 4 years of employment.
Okay. Okay. Thank you.
And John, my name's Jana. So feel free in that toolkit that you download to look for my name and shoot me an email privately if you want to discuss that more in detail.
Okay. Sounds good. Thank you.
You're welcome. Thank you, guys.